going to be co-presenting today. We're going to start off with Kathy. I think feel free, if there's any question, just don't hesitate to put up your hand or throw a bread roll at us to catch our attention. But please do feel free to interrupt if you've got any question or need some clarification, or if you've got a great idea for us in terms of improving what we're doing.
Good morning. I'm Catherine, and Natalie will be joining us shortly. Can everyone hear me? Got this a little bit high. We're going to begin talking about the Canadian context of work, and we had a meeting dinner together last evening and talked very much about there are many more similarities between our system and the Irish system. I'm most impressed with the accomplishments to date that the Institute has summarized here this morning, and in a bit of conversation that I've had going around the room, and in particular speaking with Tom on the term carer as opposed to caregiving, and the subtle differences in embracing the whole community of care. That's one element that we do share together. So we'll describe a bit of who we are as an organization and what we have learned over the years in the development and dissemination of training and resources to the palliative community. Our foundational curriculum is called LEAP, which is Learning Essential Approaches to Palliative and End-of-Life Care. And Jose will walk us through the earlier days of that program development and successes and areas for improvement, and where we are today, looking at a lot of the support that technology provides for dissemination of education, as well as the impact that we're experiencing across Canada with this and other training, the quality assurances that we're putting in place to sustain the program and keep it at a high caliber of resource, and then next steps for our program. So within the Canadian context, we're a very large geography surrounded by 3 oceans. Northern, similar to Ireland. Jose pointed out that Ireland can fit, if you see that little red, that's the province of Newfoundland, one of our 10 provinces, and Ireland fits within that. And so a lot of the dissemination of our learning is to spread across this vast geography, of which we have about 38 million now in the country. 75 to 90% live within 100 miles of the U.S. border, and then are dispersed much more rural and remotely, which is how, in fact, LEAP came into existence, to be supportive of that rural and remote community environment. We're a bilingual country, and with English and French. Our health system is on a federal basis, but funding and support are on a provincial basis. So we have to work between the 2 systems as well, then moving more locally into regional differences. So I know you were speaking this morning, and when I was talking informally, that you're trying to coalesce a program that can address a country nationally, as well as being appropriate to the different requirements and designations within your counties and your regions. Jose, is there more you wanted to add to that? Okay. Who we are. And so together, and very much as I was hearing this morning, a community, a national community of clinicians, carers, educators, academics, administrators, volunteers, and citizens who have been working together since 2001. And it began, and Jose will speak more to this, out in Western Canada. The program moved in 2011-12 to Ottawa, more Eastern Canada, and that's when I came on board. And I was so impressed with the stakeholder engagement and support for the program over this time frame, and many changes that it speaks to the need for this kind of education, as you're demonstrating by your commitment to the program in Ireland. So together we all need to be working to provide the difference that we can make. And I know, just speaking to a few of you today, you have physiotherapy, pharmacy, nursing, educators, clinicians all coming together in your teams, which is how you can provide the most effective care. Dr. Sandy Buckman is one of our National LEAP Advisory Committee members, also Assistant Professor, Department of Family and Community Medicine, University of Toronto, Clinical Lead of Primary Engagement for Cancer Care Ontario, a provincial entity, Education and Family Physician Lead in the Tammy Latner Centre for Palliative Care in Toronto, and is also past president of the College of Family Physicians, one of our advisory committee members, and he's speaking to that impact and importance that it's everyone's business to be engaged in supporting palliative care. And so very much, again, the similarities that we're expressing with both of our countries. They're supported by a very strong governance board, nationally representing government, legal, finance, industry, communications, both Jose and myself on the board. We're led by Dr. Srini Cherry, palliative care physician of Alberta. And so they're very much leading and guiding and working with us in the development of our program. We're also heavily supported by our office team, which are primarily designers and creators of the educational components, support for our participants taking our training and facilitation of it, as well as we have the National Advisory Group. We build working groups for each of the thematics we'll be talking about, and the process of engagement from the beginning of design through to the dissemination of our training is very planned to be building community as we move forward from the different areas of expertise that engage with us. And that speaks then to the broader Pallium community as well. And I was speaking with a woman this morning from the brain. We're working with the Brain Tumor Foundation as one example of a federal partnership to design a learning module from the patient perspective going through the journey of living with a brain tumor, to share that information with clinicians. So both looking at from the patient journey and from the professional needs is one example of the importance of our both national and provincial partnerships that we work with. I'll turn it over to Jose, who was introduced as co-founder of Pallium, and so can speak from those very early days forward.
Thank you. So what happened was back in 1999-2000, we started exploring e-learning before we actually had the Pallium project. And the issue was in Alberta, which is an enormously large province, we had to try to reach out to health professionals in rural and remote regions. And so we had to look at some distributed learning options. So we started exploring e-learning. And then we soon discovered that there were needs not only in Alberta, there were also needs in the other prairie provinces, Saskatchewan, Manitoba. Now those three provinces put together, I think, are probably larger than Europe, just in size. And so we said, well, let's all get together and build a community, much as what you've done here as well. So I can say to you, it's exciting to see what you're doing. We've seen that is the way to do it, is to work together, come together, work together. And so that is phase one. So in phase one, we decided to look at the rural province, at the prairie provinces, the rural focus, and we looked largely at going out into the small communities across the province. We got $250,000 funding from Health Canada, started developing our face-to-face learning, and started exploring the online, and started developing this community. That was successful, and in 2003 we got funding, again from Health Canada, to the tune of $4.2 million to build palliative care across the whole country at a primary care level. But again, it's mainly education, but we did 72 sub-projects, and looking back, I think there were a bit too many, 72, but we went out to look for innovation that was occurring and needed that spark to to be lit up and that fire to be stoked. So, for example, we found projects such as a wonderful grief and bereavement program occurring in a small rural community in Manitoba, and got those people further training and then got them to spread that model around the prairie provinces. So that's the sort of work that we did. In addition to exploring the e-learning and building what has become known as LEAP, which is the face-to-face course. And in phase 2, we started going out, as I said, to the rest of Canada, including Francophone, and started incorporating French into it as well. In phase 3, from 2012 to the present, we've received further funding, part of it from, a large part of it from the Government of Canada, and we're renewing and rebuilding the whole LEAP program. So that's what we'll be talking about today, is what did we learn in phase 1 and phase 2, and how are we applying it in phase 3, what's working, and where are the challenges and what's not working, because I think it's important to call that as well. Now, what's interesting was, you'll see on the dates, there was a gap 2008 to 2012, and during that gap there was no funding. But I think the momentum had been built up. It maintained its own life, it kept going. So that during those years, although there was no formal funding coming through, that the candle kept lit and things kept going. So it's really exciting to be able now in phase 3 to pick things up and move things forward. So in phase 2, we came up with, in phase 1, we developed something called a Rural Weekend course. And it was a retreat format for 2 days, bringing together different disciplines. So we were really into interprofessional education, which is at the time, there was very little happening, particularly for people already in practice. At the universities, they were introducing the concept of interprofessional collaboration and learning, but out in the field, it wasn't happening. So this Rural Weekend was actually one of the very first courses, and in fact, the very first course for the College of Family Physicians of Canada that brought together the different disciplines. And I remember spending months and months negotiating with the college to get the continuing medical education credits because their rules didn't allow for it. So I think we were at the forefront of that. And so we did, that Rural Weekend then became LEAP, 2-day course, interprofessional, 11 modules, could be offered in different formats. In other words, you could do it ideally 2 days back to back, or you could break it up into 4 half days, or 1 day in 1 month, another day another month. You get the point. And obviously English and French versions. Now, we had some guiding principles for LEAP. First, it is what's become known as a palliative care approach, right? That generalist level. Because we've got a problem in Canada. In Canada, unfortunately, for a number of reasons, in many provinces, not all, Alberta is an exception, but Ontario is an example of how the primary care sector is disengaged from providing palliative care. And there's this notion that it's only provided by palliative care specialist teams. So a large role of Pallium is not just education, but it's changing that culture. As we saw in that first slide from Sandy Buckman, is to say we are all in this together. And palliative care requires a strong primary basis as well as a specialist. But we've been focusing on the primary level. The interprofessional highlight already, competency-based. And you'll see more of that as we move forward. So I'm thrilled to see you're also working from a competency perspective, because I think it's extremely important. Peer-reviewed, very, very important to us. That's part of equality. It's part of making sure that what's written, what's taught, is in keeping with best practices and best evidence. So all our products have got an extensive peer review process embedded in it. LEAP takes an active constructivist approach. So the idea is that these are professionals who've experienced these experiences in their daily work, and they're able to bring that to the learning experience, and then together we build up new knowledge. So in the course, we've got lots of interactions, small group learning, large group learning, case-based learning, to elicit these stories from the different people and the learnings and the experiences. Next, I think we've already spoken about. Right, so what did we learn in phase 1 and phase 2? So a PhD student did do her thesis looking at the impact of the course on the learners. So this is changes in knowledge and changes in attitudes, changes in self-perceived comfort levels, and showed significant improvements. I've got a slide with the psychometric data, but to show that the instruments have got fairly robust psychometric properties, and showed a significant improvement. But it was interesting right across those different disciplines. Because we were wondering, if you're getting all these different disciplines together, may one be making it, more leaps than another one, as it were. But all groups, significant improvements. Now, we didn't look very much into the long term, so this is short term, and that's one of the gaps and one of the limitations, is what's the impact of the course 6 months or even a year after you've done it? And we didn't look at that, and that's something that we really have to start focusing on in the coming year and thereafter. We learned that we required a much more rigorous quality assurance strategy or process. What was happening was we thought that let's develop this course, so it becomes standardized. You don't have people across the country reinventing the wheel and developing courses, same material, same content. This is one standardized, peer-reviewed, with content from specialists in the field from across the whole country. And we said, we'll leave it out there and let people use it. Well, that was, in hindsight, a mistake. Because what happened is people were using it, but then they were changing it, modifying it. There was a license agreement that people were just basically ignoring. And so we had all these different versions appearing all over the country, people changing it. And once you start doing that, you start losing the quality assurance, because you don't know what's being put into those slides, how it's being changed, etc. So we had to tighten all that up. The facilitation we learned over the time, in some places has been done superbly well, in other cases really poor. We heard a story once of one of the facilitators who literally stood up at the podium with the facilitator manual open and read the whole thing. So that's not the intent. It's supposed to be active and participatory. So we had to improve that. And so we've done a lot of work, particularly in the last year, trying to address those issues. The CME, so for the College of Physicians, for example, provides CME credits or CPD credits. And we left it up to all the different regions. So you saw the massive, large geography to apply for these credits. And not only was it extremely expensive if you add all of it up, but there's a lot of duplication of the work. And so the College of Family Physicians actually came to us and said, look guys, just develop one central place. So we've been working on developing one central accreditation with the infrastructure, and you'll hear later on about our Pallium portal, the infrastructure that allows us now to do that from a central place. We need more data on the course, the number of courses, the number of learners, because when we were applying, when we were doing the advocacy and going to the ministry and asking for more funding, they were asking us, well, what is the impact of phase 1 and phase 2? And luckily we did have data, but I wish we had much more data. The number of courses, the number of learners from the different disciplines, impact on knowledge, etc., from all these different courses. So we realized the strength in having the data and making sure we've got the processes in place to collect that data. We also discovered the cyclical nature of capacity. A lot of it, we found out, depends on champions. So local champions pushing us forward in their regions, not even as a province, but just in the regions. But champions come and go. And so there's got to be something built in here that you can keep it alive. And if someone goes away, someone else steps into their shoes. We also learned that it's difficult to be everything for everyone. So if we looked at the evaluation, for example, a nutritionist would come to the course and say, there's only a little bit on the GI tract module, and I didn't find the rest very useful. Others would say it was very useful because now I know what my other colleagues do. But it is very difficult in some disciplines to do, as I said, everything for everyone. So we've been focusing on physicians, nurses, pharmacists, but now building more in opportunities throughout the course for other disciplines to provide their input and become involved, which I think we hadn't done very well before. In the early course, the rural weekend that then became the early leap, we divided the course up into the symptoms, pain and respiratory delirium, and then psychosocial, concepts of hope, grief, etc. And what we discovered was, particularly the physicians, were picking the symptom ones and not coming to the other ones. So we had to dismantle all of this and mix up all these modules and weave these things through the different modules to keep people in the whole course. Facilitators requiring training. We didn't do enough of this and enough support in phase 1 and phase 2. In phase 1 and phase 2, learners would come to the course, and then at the end of it, they did their post-course evaluation and went off, never to hear from us again, and we never to hear from them. So we've realized you need a leaping forward, the concept of ongoing leaping. And so with the Pallium portal we have in place now, we're able to find out who the people are, the learners, get them registered, and every time we come with a new snippet, a new doodle, which we'll be hearing about later, a new courselet, we can send it to them. And so it helps them stay engaged in this ongoing learning. There's a massive demand from different settings for LEAP. So the LEAP, the 2-day course, we realized, hang on, if we take it into long-term care facilities, the cases that we have may not necessarily resonate with those groups. We had emergency departments coming to us and say, can you do a LEAP, but you've got to change the cases to be specific to. So we heard there's a great need across different professions, across different settings. And that's what we've done now with Pallium 3, what we call the LEAP renewal. Because now we don't just have one LEAP course, we actually have a suite, a selection of courses appropriately designed for the specific settings and professionals. And we've also realized that there's a great potential for LEAP to become an agent of change, particularly around quality improvement. I think in the program I see there's quality improvement, and I think that's fantastic. And so we're trying to use now LEAP as an agent of change locally. So for example, a few weeks ago, so I'm a palliative care physician, about 40% of my time is caring for patients, and I do a lot of teaching as well. And we went to a small community called Alexandria, which is quite close to Ottawa. And in the course, the way it's designed, we soon discovered that what was happening was that there was a chart in the home for patients being cared for at home, but unfortunately it wasn't going with the patients to the hospitals or to other care settings. And so improvement was required. And so LEAP was able to actually nurture a group coming together to start to improve services in that area. We've been doing lots of things, including developing the different courses. On the top right-hand side, we're now doing a project with paramedics. So the paramedics of Nova Scotia and Prince Edward Island came to us and said, we want to train all paramedics, about 1,000, in our provinces on palliative care because we know nothing about it. So that was how we mapped out the competencies. We always start off by mapping out the competencies and then designing the course based on that. The lower left was an interesting experience because we were asked to go and develop by Cancer Care Ontario a LEAP for Aboriginal people. So we went and engaged the Aboriginal people, and they said to us, we don't want a separate LEAP. We want to be integrated within LEAP, so we become more visible. We're not a separate entity. We are Canada, and we need to be integrated in that. So the importance of engagement and listening from the stories and the needs from the field. So we've taken now, in our LEAP renewal, a Lego block approach. I hope I don't get sued by Lego. I hope they see this as an opportunity for advertising rather than making more money. So the idea is that each of these blocks is a module. And we're developing all these different modules. And then if you bring together a combination of the modules, you've got a course. But you also have some freestanding modules so that in a local community, if there is a need to do something end-stage care of Lou Gehrig's disease, ALS, or end-stage heart disease, that the local palliative care team can provide a workshop on that field without having to be limited to only a 1-day or 2-day course. So this is our development process. So we start by establishing a work group. We look across the country, who are the experts in that particular field? So for example, for long-term care, we discovered some fantastic work happening in Thunder Bay, Northwest Ontario, Erie St. Clair, Southwest Ontario, Vancouver, and Calgary. So we convened and brought together those groups to start working on LEAP for long-term care. Identified the competencies required by the different professionals. From that, develop the learning objectives. Then we go into the overall course design because you're going to select your learning methods and your products based on what those competencies or learning objectives are. Start developing the course content, and then identify peer reviewers from across the country, content experts who know that field. And for each of the products, we have to have at least 5 or 6 peer reviewers, not just 1 or 2. And then once the content is produced, it goes out to peer reviewers, we get back input, further modifications are made. We make sure we integrate an evaluation framework that at the very least is looking at changes in knowledge, attitude, skills. And then we start piloting, and then at that point we go into, some of you may recognize the PDSA cycle. So we do 2 or 3 courses, evaluate, come back to go back to the drawing board, modify, go back, apply, until we reach, from a qualitative research perspective, you've heard of saturation, right? When we reach saturation, where the learners are coming back and saying this is good, and the changes are not major, at that point we then lock in the course. Because if you lock the courses in too early, it's an enormous amount of money that you spend locking it in, only to change it again. So for several months, the courseware is temporary until we lock it in. And then once it's locked in, that whole big cycle starts again, where you go back to what's the evaluations coming in, let's go back to the course design. So you enter into the cycle. So LEAP Core, for example, we've gone through this whole circle, and we're back to looking at the overall course design and doing some further peer review again. Long-term care, we're about to start that piloting PDSA cycle. Emergency department, we're at the beginning I think we're in the content now, Natalie, developing the content for that course. So we've got these different working groups across the country working on these different courses based on a template. So our LEAP, you can see on the top there, LEAP Core. So that what was known as LEAP has now become known as LEAP Core. It's the 2-day program. We've got a LEAP Mini, and that came because we had some family medicine clinics from across the country come to us and say, you know what, we can't dedicate 2 full days. We've got to learn about diabetes. We have to learn about abuse of elders. There's so many things we've got to learn about, so we can't do 2 days. So we've modified it into a LEAP Mini, where we focus on the top 10 tips for each of the areas. Top 10 tips for pain, top 10 tips for delirium, etc. And instead of using long cases for long discussions, we rely on small little cases, which we refer to as vignettes. LEAP Onco is also a 1-day program. The cases are specific, or the vignettes are specific around cancer patients, and it's targeting oncologists, nurses, pharmacists, radiotherapists who work in cancer centers. We've spoken about LEAP long-term care. We've spoken about LEAP paramedics. The paramedics have asked us for a day. So it's about 7 hours of training. That's what they could do. And that's being piloted. I think we've just done...
we're piloting 998 students right to September.
Yeah. So very big project. LEAP Emergency Department, I think they've asked for a 1-day. And we were astounded when a group of surgeons came to us and said, we've heard about LEAP, we want something for surgeons. So we've got a working group now with a group of 6 or 7 surgeons, some from across the country. They've identified the competencies, and they're about to now start doing the design of the course. And it was the best group I've ever worked with. There was none of this, I think we should change that word or change the order of the words. It was, okay, good, I like that, okay, change that, that's good. It was just so quick. Then LEAP undergraduate, so across the medical schools, we've got 17 medical schools in Canada, and the curricula are different in each of those schools. So there's no ways of doing one standardized curriculum for each of those medical schools. So we've come up with a concept of a basket. And in this basket, a whole lot of goodies, the doodles, the snippets, these courses. So all sorts of products that local school can then go into and pick out the things that work for them, put it onto their shopping trolley, as it were, and go in and implement it. So, and that's how we're seeing it happening. In fact, we've just finished now a program in the Schulich Medical School in London, Ontario, where 168 medical students just completed a modified version of LEAP. Remember, LEAP is constructivism, but these medical students haven't had the experiences in seeing these cases, so we found there was something that just wasn't clicking. And so we had to modify it specifically for the undergraduate. So the ones in color are the programs are either completed or being developed, and then the gray ones are ones that are going to be coming up in the future. And you can see the Aboriginal peoples, so they're learning. So for example, here's an example. And we speak about the 4 domains, there's physical, psychological, social, spiritual. Well, in the different peoples, the Aboriginal peoples, they speak of the 4 colors, they speak of the 4 directions. The 4 Mother Nature components. And so we're able to bring those concepts into the courses and thereby valuing the input of our Aboriginal peoples. Competency is very important. We started using a process called DACM, and if you want to read a little bit about what the DACM process is, this was published in the Journal of Pallium Medicine in 2010. This was an interesting exercise because here we said to the chaplains working in palliative care teams, what are the competencies you require? And they first said, well, we know what they are, we don't need further training. But then when we actually brought them together and said, okay, exactly what do you need to be able to do in order to practice as a chaplain in a palliative care team? They started mapping it out, and at the end of the 2-day process, using this DACM, they said, this is an amazing experience. And as a result of that, we actually developed in Regina, a team in Regina in Saskatchewan took on the role of developing a program for these learners. We're using the primary level palliative care competencies to build on the other competencies. So for example, with the surgeons, we said to them, here are our family physician competencies. Which of these resonate for you? Which ones are appropriate? Which ones are not? Where are the missing ones? And so it's helped us speed up the process. Instead of going into the usual DACM, which takes 2 or 3 days, we've been able to shorten that almost to half a day now by saying, here is something, here's a straw dog, work with it, modify it.
So these are the paramedic competencies that were identified at the DACM that we held, the modified DACM. And it was very interesting because before the meeting, they had actually addressed challenges and barriers within being a paramedic and providing a palliative approach to care. And we built off of that. And they identified these domains, and in each domain, specific competencies that they would like when providing a palliative care approach to their patients. And to change from transfer to hospital right away to really being able to provide care in the home. And I think that's been one of the most interesting, because I'm getting calls now that they've done the education, that their whole culture has changed because they can provide care in the home and don't have to transfer right away when it's not appropriate.
So there are different ways of mapping out competencies. We spoke about DACM. We've also used modified DACM processes. And more recently, as I said, we call it the rapid prototyping, because there's such a need to have this course that we can't go through the long, drawn-out process of developing the competencies and then going with the course. So it's almost happening in parallel, where we do some rapid prototyping, come up with a prototype of the competencies, put the course, start developing the course, and then in a cyclical way keep coming back and refining each of those, if that makes any sense. Because in the first leap, it took about 6 months, 8 months from defining all these competencies, going out to people in the field, vetting it, to the time we were ready to then roll out the course design.
And it works very well that way because for the paramedics, they had actually 5 hours of palliative care education content and 2 hours of project specific. So while we were doing the content, we could go back and say this competency hasn't been addressed, so they would provide cases that address the competency or a video, so it wasn't long theory bursts, but quite quick.
And what we're finding is as they now start doing the learning and actually become more attuned to what's happening in the field, they're coming back and saying, there's a competency we missed. And so we were able to modify that. And so the vision is that in a few years' time, we're going to have even more robust competency maps for all the different professions across the different settings. This is a quick program of our 2-day course. You can just see some of the modules. We start off with being aware, a 1-hour self-reflective exercise on experiences people have had caring for someone who had a progressive life-limiting illness. The taking ownership module is a standalone module that we can go into family medicine clinics, for example, or cardiology clinics, or neurology clinics and say, listen, you've got an important role to play in this. It's not just the domain of specialists. So the whole module is designed to engage them and say, do something about it, and we've got a course that we can come and do for you.
It's also the module that's in all of our curriculum, so LEAP Long-Term Care, LEAP Core, LEAP Mini, Mini Onco.
Okay, that's our one-day course, focusing on the top tips, as I said before. We use different learning methods, everything from, as I've mentioned, really large group discussions, small group discussions, case-based learning, and then something we call theory bursts, but are actually interactive overviews. So when you've got different professionals coming together, we found that there's sometimes differences in the base knowledge and base experiences. So you need to bring everyone up to speed to the same point, and then do the cases from then onwards. So we use these theory bursts that can last anything from about 15 minutes to half an hour to bring everyone to a common understanding, which then we've found helps then do the case-based learning. We limit the size of LEAP to 30 learners. LEAP Mini, we take up to 40 or 50 learners, and we've got requirements in terms of the number of facilitators required. So for a course of 30 people, we require at least 3 facilitators from the different disciplines to make it really interactive and to be able to break up into small groups, come together into large groups, etc.
So this is just simply a list of all of our other products that help support the LEAP courseware as well and act as standalones. So we have the doodles and snippets, which we've been seeing actually decrease the number of slides needed in theory bursts, because you can cover 10 to 15 slides in a 2-minute video, as well as trigger videos that use the not quite right approach, participant manuals, facilitator manuals, and our Pallium portal, which we'll go through a little later, but has been quite resource for LEAP.
Some of you are probably wondering what is meant by not quite right. In fact, we did a presentation once where I think the title was When Mediocrity is Better Than Perfection. And that became quite controversial because my medical school basically said, we don't want you to be going around talking about mediocrity, we for perfection. But the concept is, we discovered in phase 1 and phase 2, when you develop these short trigger videos of 2 or 3 minutes long, and you try and do it beautifully, what happens is 2 things. Well, one is you can never get it right because there's always a different way of doing it, a better way of doing it. But secondly, it looked as though the learners would look at it and say, oh, that's great. And the reflective processes stopped. The cognitive reflective process stopped. When we showed really bad behavior, it was, oh, that's a stereotyping, and then also stopped. So we have these videos where at the end of watching it, you think, that's not bad, but there's something that's just not quite right about it. And that triggers the discussions. Right, these are just samples from the manuals. Obviously, in the facilitator manual, you'll have some notes for facilitators. They're not going to be present in the learner's manual. And there's little icons that directs people. There's navigational aids that directs the learners and the facilitators as well. So I just want to highlight some of the thematic, so unique features.
Thank you. The one we've spent the most considerable time on is LEAP for long-term care. And it, in fact, was one of the thematics that had begun during that time of hiatus that Jose spoke about by those very interested, engaged stakeholders working in the long-term care environment. And so when we reconvened in 2012, we brought them together and further developed the thematic, which is to be piloted this June. Part of that, and you'll be familiar with the model of palliative care, and looking at where an individual enters into a long-term care environment. Across the top of the module, you're seeing the palliative performance scale, and down on the left-hand side, the point of admission is where an individual, a resident, has evolved in their illness to a 40 to 60% of palliative need or care needs. And the triangles and rectangles across the continuum of an environment in long-term care are different transition points that a resident would experience. And we've developed essential conversations to assist both the carers and the residents in situation. So very much taking the core program, adapting it to the environment of long-term care, where this is your home, where you come to live out your days. And that's part of a cultural shift as well, to finally have long-term care homes embrace the kind of care that they have been providing, but having now the tools to be able to do that. So very much adapting from the core, because it was all encompassing, but bringing in much more the allied health perspective, because they are the primary care providers. So we have taken the traditional core, of which you saw the different modules, and brought together the full team, including allied health. We call them personal support workers in the environment, and we've divided it out between the 2 days so that there's a coming together for the education and learning on being aware, and it's everyone's business, and understanding the context of working in a long-term care environment, to then having for the MDs, RNs, and pharmacy social work breakout into more of the physical clinical support issues, whereby then we've now created a specific learning and training for the allied health to both empower them when they go back into their home environments, to be able to both have the consistent terminology and understanding of a palliative approach, but competencies that they are able to display in their home and to train others in the home. So this is a new addition to the curriculum development, a very big piece in the empowerment overall, because it is 70 to 80% PSW allied health frontline caregivers that will now be able to be much more supportive in their observations and reporting to the nurse, to the pharmacy, and to the medical profession. This is an example of a case that then has been adapted from the core to reflect more of the kind of resident that would be in a long-term care environment, and this would be presented together within the module of understanding the different components of illness trajectory and how would you deal with this situation.
I was just to add there as well, what you're going to see is, although there are modules and it's sort of divided up thematically in the modules, we have weaved in throughout the program ethics, communication, so it becomes weaved in right across. And so here's an example of an ethical issue, but also obviously an important clinical issue.
And this is just another example from our newer thematic on LEAP for paramedics. And they themselves, in Nova Scotia, these are actual paramedics that wrote scripts based on their experiences, and then were filmed and embraced the not quite right, so that they weren't concerned about having a perfect product. But very much, this one in particular is talking about the daughter that flies in to help care for a parent, whereas the son has power of attorney and has been on the ground with his father all along, and the paramedic trying to, one wants them to go to the hospital, the other is saying that they have the kind of care that they need right in the home. So very much adapting to the environment, this from a paramedic perspective. So the impact of the program, Jose.
So as I said, up until now we've been looking at the impact, the short-term impact. But now, so we have instruments that we've developed. One looks at, it's a quiz. For LEAP Core, for example, it's a 20-question multiple choice quiz. There's an attitude survey we've developed. There's a comfort scale that we've developed, and we've got, we're doing research on the psychometric properties of these instruments. But the instruments are actually part of the learning process. And it's interesting because we're stuck in a little bit of a dilemma at the moment, in that is, when we go to the accrediting colleges and we say we require that the learners do these instruments, they say no, it's got to be optional, it's got to be, you can't force people to do it. We're saying, but it is part of the learning process. It's not just about us collecting data to see if it makes a difference. More importantly, The pre-course survey is actually to get people thinking about, are there questions I may have? How do I feel about certain issues? What's my comfort in communicating specific issues? For example, responding to someone says, how long do I have to live? And so we've got the pre-course reflection, we've got the post-course reflection, it's the same instruments. With the comfort, there's a fascinating approach in research that's pre versus post. In other words, at the end of a program, you ask the person, looking back to before you started this, what do you think your comfort level was? And now what do you think it is? Because often before, people actually rate their comfort levels higher than they're actually, and once they go through the program, they realize, oh my goodness, I don't know about that. So it's just an interesting bit of research we're doing in that area. Then there's a 4-month, so at the end of the course, we ask them to do a commitment to change. There's a form, they have to identify 4 to 5 things that they will commit to change in their daily practice. And they describe what those are. We collect that, and 4 months later, using the Pallium portal, we are now electronically able to send messages back to them and say, these are the commitments that you've committed to. To what extent have you implemented them? And that's part of the reflection. And for physicians, for the highest level of credits, you have to do that. And we're trying to get all the other professions to do it as well. And it's interesting, we're beginning to collect some fascinating data, qualitative data, about what is it that they identify that they want to change, and 4 to 5 months later, have they been able to change? Because they have to provide examples of how they've implemented their commitment.
So this is just an example of the attitudes reflection data. So this is just analyzed pre and post. The pre is on the left, and it's answering the question, dying persons make me feel uneasy. And you do see that in the post there is increased comfort and knowledge on how to deal with that. And you'll also see one of the challenges is having participants complete the post-learning reflections. There's quite a few more in the pre, but we're working through that through online methods. And
it's happening online, but as soon as they finish the course, they walk away, and it's a real challenge to get them to do this. So we're still trying to work on a strategy on how we can capture all that, not, as I said, not just the data, but also that reflective component of the learning. This is an example of one small course. So now through the Pallium portal, at any day, Natalie can go in and see for that course what were the results, and collectively what have the results been. So that's a part of our beginning to develop this database.
And this is the commitment to change document that's filled out immediately after the course and 4 months after. And in the 4 months after, there's a checkbox that says, did I complete this, did I not, and why, if not.
So, just by show of hands, how many know Kirkpatrick's levels of evaluation? I'm sure many of you do. Right, so we haven't reached the holy grail yet of seeing large-scale data on changes in an organization and direct benefits to patients or clients. We're hearing anecdotes, we're hearing stories, and we're trying now to find ways to capture that. And so I think going forward, it's going to be one of our big pushes, is to develop a whole research stream about how can we explore changes. For example, and we begin to do that. We're doing a project with Cancer Care Ontario, where we're going to family medicine clinics. And now we have the capacity to go back and using billings, physician billings to the health ministry, to try to tie that up with practices. So we've got, for example, we've just seen recently in Ottawa, where a family medicine clinic has significantly increased the number of patients it's identifying as palliative care. So we're beginning to explore that.
So Dr. Breyer spoke a bit about quality assurance of all our LEAP products, and that is done through quite extensive peer review process, and having different approaches for the different facilitators to make it their own while also making sure it remains standardized. So we do now have a central CME accreditation process. Local facilitators connect with us, and we provide the CPD credits for physicians, as well as quite a robust facilitator training program that's both face-to-face for new facilitators, but has a follow-up e-learning. So at any time, a facilitator can log into the portal and they have a long list of resources that they can access for when they're preparing for face-to-face and also following up with participants later on. A lot of our facilitators at the end of the face-to-face give them participants their contact information on how to follow up when the next case comes up. So it really provides an avenue.
And briefly speaking to our quality assurance through our facilitator training within Pallium, recognizing both during the earlier years of Pallium when we had wonderful facilitators leading our curriculum, and then through that period of time when they were continuing to do that, and for our revitalization, wanting to bring them under the umbrella of Pallium again, we created a 3-hour online reorientation for those existing facilitators, and then have gone across the country inviting new facilitators that meet particular criteria, both in their clinical practice, their experience in palliative care, and ability to be a teacher facilitator. And we bring them together for a one-day how to be a facilitator, and bringing them up to speed on the newer components of our curriculum, as well as supporting, as Natalie said, beyond the training, so that we have continual dialogue with them and support when they're out in the field. Part of transitioning as well is to embrace clinical experts who may not have had the particular training but are very ingrained in a palliative approach to care. And so bringing them into Pallium and supporting them through a tiered approach of becoming a collaborator in more recent training and moving into a facilitator and then into a master facilitator role. Just over this past year, we've been able to branch across Canada and training over 1,000 participants through our facilitator training components, and we're moving forward in the next 2 years with our federal grant to reach more sites and to empower through the facilitation, because we don't go out and do the direct delivery, and it's building the community capacity and the facilitator training capacity that is so essential for a palliative approach to care. We are looking very much at strengthening communities with training as a mechanism to do that. Part of in the toolkit, in the portal, are checklists for different organizations on how to prepare, as Karen has done so beautifully today, to host a session and to support participants into the LEAP program. Now our portal, and we're going to talk about this more in the afternoon session, I'm not sure. Do you want to move into this quickly, or?
Sure. So what we're learning is the power of partnerships. So exactly what you're doing, working together, finding partners such as the universities. I mean, it's astounding that you've got formally the universities joined up. We don't have that. So that's one of the ideas we're going to go back with and really try and engage the universities. Jump at opportunities. When we started off, we weren't going to do a LEAP oncology. But an opportunity came up. The opportunity of the paramedics, when they came to us, it's really to roll with that without diluting the core work either, but rather strengthening it. The importance of continuous advocacy, and Kathy does an amazing job with that at the different levels of government, right? So federal, provincial, and then regional. The power of social media, I'm beginning to learn. We've got some fantastic young people who are working on that. Skilled manpower is a major challenge. It's finding all the peer reviewers, the content. It takes a lot of time to find all these people.
Just very quickly, and I know you're interested in sustainability modeling, and we're looking at that as well for ourselves, and to be able to continue to provide the very needed training and resources. And at this point, we have a very modest portal access fee for the different curriculum by participants, and as well have crafted a framework for costing for different presentations in organizations, including the facilitator training or facilitator presentation, the materials, the venue, etc. We're looking at, through our portal access, though, other avenues that are both accessible and effective for different levels of participation across the country, whether as a participant in a particular curriculum or more a public interest into some of our doodles and snippets, and trying to build an engaged community through the online, which is very similar to the work that you're doing. And I believe Jose is going to speak more with you tomorrow on that in the steering committee. So very much going forward, looking as you are for financial sustainability. I believe, though, even societally, the recognition and understanding of the importance of palliative care is forever increasing, and government awareness is heightening. So we're all in the forefront of that, and the timing is very good for us to be supported more sustainably. Palliative care, as we all know, is a much more cost-effective place of care, supporting individuals and families where they prefer to be. And so enabling it through education and support enhances that as well. Anything further on future?
I think the big thing is, and we're going to end off here, is compassionate communities. So we're stepping now into the area of compassionate communities. We're aware of some fantastic projects occurring across the world. We've heard about it in Oxford, in Edinburgh, Pamplona, of school projects going into schools. And Kathy has actually done some of that early work in the States when you worked in the States. So we're looking at compassionate schools by going into training programs with schools. We're currently working with the Catholic School Board in Ottawa. We're looking at compassionate companies, developing programs where we go to companies to speak to them, to bring awareness about palliative end-of-life care needs. In Canada, we've got a compassionate care program where for 6 months, a caregiver, family member, can get unemployment insurance to look after a family member who's terminally ill. So we want to bring that to the attention of the companies. So that's we'll be hosting a conference October 28th in Ottawa to look at compassionate communities. I think that's probably the most important thing. So I know we're sort of at the end of our time. I'm sorry we weren't very interactive, certainly not very constructive. We've had so much to share. But maybe what we think of doing is we take the break, and then there's going to be time with the next session where we can bring this all together. Oh, sure. Okay, cool. Thank you.
We have some time for questions, and I'm heartened that you're talking about compassionate communities, because we have people from Limerick and we have people from Foyle Hospice who are engaged in some projects. So if you want to touch base with, and we also have Barbara Sweeney from St. Francis Hospice, who runs with her colleagues there in St. Francis, Raheny and Blanchard, fantastic interactive project with schools in the catchment of St. Francis, with transition year students, and their knowledge and their change in knowledge and their understanding of palliative care and end-of-life care is considerably changed with that interaction, which is really good. So we do have time for questions, and we do have roving mics. So if anybody has a question, if you pull up your hand, and one of us will get to you with a mic.
Thanks very much. That was a great presentation and a lot of really interesting ideas there. One question I had was in relation to the PDSA cycle, and you said you wait a certain period of time before you lock it in. Typically, how long would you let it go on for before you would do that?
We discovered that in the first leap, there were about 16 courses. I don't know what's going to happen with LEAP long-term care. We're waiting to see, but I suspect it's somewhere around 8 to 10 courses.
For 10 cycles.
In other words, you do so 2 or 3 is the cycle. So you do 2 or 3 courses. You bring in the evaluation results, sit down, look at them, modify, back in again until when you've done, I think somewhere around, we believe, 10, 12 courses. So it's about 3 or 4 times around that wheel, you then lock in.
So we actually started, we released LEAP Core, the renewal, in September, and we're about there. I've been analyzing the data and the feedback coming back from facilitators, and it's now starting to repeat. So it should be about this year. Definitely lock in.
Thanks, Patricia. Kevin?
Thank you very much for a very interesting presentation there. The one question I had is that what IT expertise have you got to support all of this?
That's a very good question. As we'll talk a bit later about our portal, which was something that was built over the summer, and we had intended for it to be piloted over the fall, but we tweaked it to have since then over 3,000 participants enter into it with some varying levels of success and frustration. We're on a Moodle platform and have contracted with a third-party company to develop and work with us. We have an e-designer on site who is an e-expert in graphic design, so the development of the curriculum is in-house, but the actual hosting it on the platform is an external process that, again, part of the piloting of both the portal and the training is giving us this very valuable feedback that we're still in a development cycle. Do you want to add?
Yeah, I was just going to add for our medical content, our peer review, that's why it's so important, because we use Savvy Docs. It's a cloud software where we can have anyone who has internet access with the medical expertise goes in and writes notes, and it all comes to me, and it's all collated already, and so it saves a lot of time, and it's blinded. So we have that blinded peer review from medical experts around the world. It comes already collated, and all I need to do is then present it to our scientific officer, and it saves quite a bit of time.
But having in-house IT, I think, is important. And as we're going to see with the e-learning piece, finding software that's easy to use. In phase 2, we tried to do these online learning courses, and we failed, largely because the software was so expensive, the instructional design was so expensive at the time, and to get that IT support was extraordinarily expensive. Today, we use a software called Articulate. It is so easy, it's so quick. So things have changed a lot in just 6 or 7 years, I think.